Find out how to get involved or to locate an event near you, visit the Recovery Month website at recoverymonth.gov.
Welcome back. Gary, I want to continue because you did get to mention the special considerations that have to be made for racial and ethnic families. Can you expand on that?
Yeah, I believe that what we have to do is a much better job of understanding that we need to embrace and understand ethnicity and racial differences within our country and our world in general, but also within our community. And so we're not immune to some of the same issues that occur in the general public. I think that families who are, and particularly LGBTQ families that are raising children very often who have been adopted cross-racially, one has to be able to let go of the fantasy that somehow one has rescued this child and bringing them into a quote-unquote better life, and very often has to do some really hard work about what it means to be raising a child who is racially different, and how the community supports and what the community supports are going to be.
I think of the work of Dr. Caitlin Ryan in the Family Acceptance Project, and she has profiled for 10 years different family systems, including a large percentage of minority individuals who are raising children and who are gay identified or lesbian, gay, or bisexual or transgender identified, and through her work have been able to not only accept their children, but in the acceptance of their children have improved the outcomes. That the children that are involved in her project, as they develop, are least likely to involve themselves with alcohol and drugs, more likely to complete their education, set career goals for themselves, and we see a decrease in suicide and decrease in HIV infection that occurs among the people that have participated in her programs. She also adds to that when we talk about minority groups, not so much a minority, but there's several different faith-based families that can be very conflicted by what they're learning in their particular religion, whatever sect it may be, who are getting conflicting messages. And she has a series of tapes that she has prepared for the faith communities to also better understand how it doesn't have to be a conflict between your faith and your acceptance of your LGBT adolescents.
I mean, there are programs like One Church, One Child that has come out of the Child Welfare League of America, where there can be affirming work that can be done. There are what are referred to as reconciling congregations that are really doing very positive work to affirm the lives lived of all of the members of their congregations, and to really normalize people as part of congregations, and that creates another sense of community. And I'm pleased to belong to one of those congregations. What a difference it makes for the families.
And I want to go back to your question earlier about coverage, because speaking of some of the disparities that affect racial and ethnic minority communities, LGBT communities of color, one of those disparities is a lack of access to health insurance coverage. So African Americans, Latinos, American Indians, and other racial and ethnic minority groups are disproportionately likely to not have access to health insurance coverage, which is one of the reasons why, as we're making these changes with the Affordable Care Act, that we are opening up opportunities for folks to get better access to the health care that they need by using sliding scale subsidies, premium assistance, through the health insurance marketplaces or through Medicaid to get access to coverage for the health care that they actually need, which now includes, as I mentioned, mental health, substance use, and other behavioral health treatment. And SAMHSA has actually done quite a bit to make information about the health insurance marketplaces and Medicaid available for LGBTQ communities. There's actually a resource, ACA Enrollment Assistance for LGBT Communities, and it's actually a resource for behavioral health providers specifically. And it includes a couple of different materials that behavioral health providers themselves can read to better understand what the Affordable Care Act does and how to speak with their LGBT patients about that, and resources for LGBT patients themselves to take home to think about what is my situation vis-a-vis access to coverage, vis-a-vis access to care, and how might I be able to use opportunities under the Affordable Care Act to get the care that I need.
And I know that SAMHSA also has quite a number of tips related to LGBTQ, and it has also conducted quite a bit of training for physicians, you know, so. And it brings me to the point, David, that we really do need to also address the whole issue of trauma-informed care for the LGBT community. And what does that look like?
I think that's a tremendously important thing that we're just now kind of beginning to incorporate into all levels of care. I think we used to conceive trauma as a major event, like a car accident or a natural disaster, and certainly those things are traumatic. But what Gary mentioned earlier about bullying, I think we see now that a lot of LGBTQ youth experience chronic bullying, which also results in the very same symptoms of trauma, and really require that incorporation of trauma into mental health care and substance abuse care as well. And it affects HIV, it affects all the other kind of risk behaviors that we see across the line.
Very good. And how do we move on, and any of you that may have had some experience with this, how do we move on to really making sure that the healthcare professions, really everyone within the healthcare professions, are trained to be able to deliver these services?
I think that's a great question. A recent article in the Journal of Public Health talks about the disparity in training for healthcare providers to work with LGBTQ populations. Institutions have to be proactive. I'm working on a project now in Boston with Brigham and Women's Hospital that is really involved from the top down to begin to look at itself to say, okay, we want to be a gay affirming, we want to be embracing of all of the communities, not only the people who come through our doors, but the people who work for us who are also receiving our care. What do we need to do? And the ways in which we are, as part of this project, beginning to think about how do you begin to think about what are some best practices that institutions can do, and what is the evidence that leads to success?
And two big concepts that I think are really related as part of this conversation are both cultural competency and clinical competency, particularly if you're looking, for example, at issues of mental and behavioral health conditions that may have specific treatment needs, and particularly when you're looking at transgender individuals.
Exactly.
Making sure that clinicians are able to access resources that are clinically appropriate so that they feel like they know what to do in terms of providing the right kind of treatment that their patients need, and culturally competent to recognize, as Gary was saying, where folks are coming from and make sure that they're making those connections on a personal level, on a trust level, that can really facilitate the provision of the highest quality mental and behavioral health care.
I also want to add that NowGap was very instrumental in working with SAMHSA in developing the provider's guide on providing services to LGBT individuals. And now the ATTC, we did the initial training of trainers, and now we're revisiting that. We just met over this past year as one of the consultants on that project to revitalize the training curriculum, and we're going to be rolling that out. So there'll be training available through the ATT system for individuals who are interested in developing and increasing their competency in working with the LGBT population.
Actually, I think that some of the ATTCs are already training, because I saw something come across my email system related to LGBTQ.
Correct.
And
well, the
HIV.
newest curriculum just got approved to be rolled out, which is great.
David, you wanted to add
I was just going to say, I think a lot of behavioral health providers tend to think of LGBTQ issues as just a specialty that they're not really affected by. And I think as the population, especially with the increased healthcare access, gets more integrated in general, people are going to be encountering that population and really need to, as a general rule of thumb, I think we need to increase the capability of our workforce to be knowledgeable, at least at a minimal level, and smart enough to refer or identify, and certainly not re-shame or stigmatize or do further damage.
And I think we really are at a time where there's a lot of changes happening. As you mentioned, David, bringing more people, more LGBT people into healthcare systems, the social changes that are happening that are allowing more folks to come out earlier, come out younger, and some of the efforts that have been made to increase data collection about sexual orientation and gender identity in clinical settings. And it's really important, I think, that a lot of the initiatives around cultural competency and non-discrimination are moving forward in tandem with efforts to increase data collection so that LGBT people can feel safe sharing information about themselves with their clinicians, and then their clinicians can have that information that helps them better understand where their LGBT patients are and what they need.
Very good. And so I want to come back to you, Gary. I know you wanted to say something, but I'm going to come back to you related to the older Americans in particular, because I think this is a good segue to be able to broaden a little bit that discussion. We'll be right back.
I got into recovery at a very early age, I thought. It was in my mid-20s. I knew I had a problem. I didn't know what to do about it, but I was lucky enough to have several family members who were in 12-step program. And so I knew about the existence of program. I saw what it had done with their lives. And although I thought I wasn't quite ready for it, I took a chance, and that probably saved my life, because I certainly had very close role models for me in terms of my family to show me what could be done and what support was available. I think recovery for the LGBT community and an individual is extremely important, just because of the experience of shame and stigma over the lifetime. And I look at most LGBT people and look at layers of shame about being having a different gender identity, sometimes having a different sexual orientation, being an addict, sometimes being HIV positive, being on disability, just layer after layer of shame that just can really bury someone. And that's why I think program and recovery in general gives people resilience and hope. And I think we're all about hope.
I was so afraid life was going to pass me by, and I was never know what it would be like to be me.
You know, a lot of people don't know what kinds of resources are out there in terms of affirming healthcare for LGBTQ folks. A lot of people assume that they can't afford to access these resources. A lot of people assume that they're just going to face more discrimination in these places.
It's pretty obvious that if you're part of a population that people don't understand and that tend to treat you wrong, and so you hide behind yourself, that there's a lot of work that has to be done so that providers understand this. It's hard for providers and others to understand them if people won't tell them about themselves.
You don't have to drink through this. You don't have to use drugs. And it's just really okay to be yourself.
If we're serious about ending health disparities, we really need to be serious about transforming just like systems of oppression.
The nurse practitioner for my primary care doctor, he is just awesome. You know, when we're talking about, moving forward as a transgender, he makes me feel like a human being, and this is like a normal thing to do.
That, I think, is like sort of like the first step when you're working with marginalized people. You know, it's not just keeping them in a position where they're still like being served or receiving something, but not actually getting power or not actually developing a sense of self-efficacy. It's about, meeting people's needs while also building their power.
Without all this help, left to my own devices, I'd still be scared. Fear used to rule my life, and it doesn't today.
It takes many hands to build a healthy life. Recovery from mental and substance use disorders is possible with the support of my community. Join the Voices for Recovery. Visible, vocal, valuable.
For confidential information on mental and substance use disorders, including prevention and treatment referral for you or someone you know, call 1-800-662-HELP. Brought to you by the U.S. Department of Health and Human Services.
Welcome back. Gary, we were talking about earlier about specialized treatment and the training that providers need to have. And earlier in the second panel, I think you mentioned issues related to older Americans. I wanted to come back and give you an opportunity to tell us what specific approaches people need to have with older LGBTQ community.
First of all is to understand the historical context in which people have existed. The coming out process, the identification process, the ways in which people think about themselves in terms of their sexual identity.